All right, everybody. Thank you so much for joining in today. I am here with Kaylee Dayton, who is a nurse practitioner, and she's just going to introduce herself and share a little bit about who she is, what she does, and what she's passionate about.
Thank you so much, Nicole, for having me. And I'm really proud of all of your work and your community that you've built. Um, I would consider you guys revolutionists in your own sort, fighting for evidence-based practices and change at the bedside. I am so excited to be a part of that today. Uh, I started my nursing career as a brand new nurse in a medical surgical ICU that I now call an awake and a walking ICU. So this is over 10 years ago, but this ICU for almost 30 years has allowed almost every patient to wake up right after intubation and mobilize shortly after. And when I say that, a lot of people roll their eyes. They're like, okay, so your patients aren't sick. Those are long-term venters, whatever. So it has a bone marrow transplant unit in the hospital. There's a detox unit down the hall. It's right next to a homeless shelter. There's a drug park around the corner. There's a psych unit. I mean, so we get a lot of septic shock, multi-organ failure. Informally, for years, it's been an ARDS unit in a sense. We get transfers from all over the region for ARDS because of their practices and outcomes for patients on mechanical ventilation for prolonged periods of time. So these are high acuity patients. I had one of the highest acuity COVID units in the state of Utah throughout the pandemic, and yet they continued this practice of asking at each intubation, does this patient have an indication for sedation? So for me as a brand new nurse, even in the interview, the nurse manager asked me, would you be willing to walk patients on ventilators? And as a totally naive, super excited, zealous new graduate, right? I was like, yes, absolutely. I'm all about that, whatever that is, right? Like I didn't even know what that meant, but it never was a big deal because that was the culture there. And this is how powerful culture is, right? They treated walking patients on a PEEP of 18 and 100%, like almost as routine as giving an antibiotic. Not that every patient was on those settings, right? But if a patient was oxygenating with movement, we were just doing their highest level of mobility and assessing as we went. And it was just everyone was comfortable with those skills. They do 3 mobility sessions a day. The first 2 are with physical therapy and the nurse, RT. And then at night, it was just me as a nurse with an RT, CNA, walking my patients around the hall. And that's how I got a quiet night, right? Like that was just part of the routine. Then they actually got real sleep, and it was just so normal. And when I went to be a travel nurse after a few years, one of the founders of that unit, well, the main pioneer, Polly Bailey, she started this process as a nurse back in the 90s when there was no evidence. She was going off of intuition with a little bit of buy-in from her medical director, right? So here she is 20 some odd years later telling me as I'm leaving that unit, just know things are going to be different elsewhere. And I was like, yeah, I know. I'm in it for the adventure. And I went to another unit in my first shift. Everything was dark. It was day shift, but the lights were still down. Everyone was in bed. They all looked like they were sleeping. And I got my patient assignment and they were sedated and intubated. And there's nothing about their acuity or their diagnosis that would make me um, want to sedate them or think that they had to be sedated. So I was confused. So I asked my orienting nurse, hey, can I take sedation off and get this patient up? And she just withdrew in horror and said, no, they're intubated, which in my naivete, right, it made no sense to me because for years I'd walked probably hundreds, if not beyond, close to 1,000 patients that were intubated on mechanical ventilation during acute respiratory failure. And so I innocently said, oh, I know that they're intubated, but why are they sedated? And she said, probably getting more concerned, questioning whether or not I had any ICU experience, and said, because they're intubated. So we went in circles with this, and I started to question myself. I thought maybe I'm the crazy person. And I realized how alone I was in that perspective. I didn't know enough about why we did those things to really defend my practices. I didn't know the evidence, which is unfortunate. Nursing is an evidence-based practice, so we should all have the right and the opportunity to bring the evidence to the table, but I didn't know it. And I didn't really dive into it because I just went with what was normal. I went with the cultural practices. So for another 2 some odd years, as a travel nurse, I went with the win and roam approach and kept going. And so later I went back as a nurse, as a graduate student, back to that ICU. And I started to look into the research. And then during my residency in that unit, I started to realize that there was a huge discrepancy between what that ICU was doing and what we were doing throughout even the rest of the hospital system. I was doing float pool, and I was noticing that this was the only hospital in that entire system that really walked patients on ventilators. And so I started to really dive into research, to survivor testimonials, and saw a completely different perspective. And I just really felt like the ICU community deserved to know what the evidence shows and what really patients really experience during and after mechanical ventilation and deep sedation. And that's how I started the podcast, Walking Home from the ICU. And that has from there turned into consulting to help teams become awake and walking ICUs.
Wow, that's pretty incredible. Thank you so much for sharing that. Um, just based on the accounts that you've gotten from patients and interviews that you've done, what's a highlight that they've said that's kind of stuck out to you to where when they have been awake and walking, what do they remember and what are the benefits from that?
Yeah, the survivors that have been awake on mechanical ventilation are so glad that they were allowed to fight for their own lives. They were glad that they were able to connect with their families. One survivor, I've learned so much from them, things that I wouldn't have thought about. He said during his severest of ARDS, I'm so glad that I was able to support my wife during that. I don't know how she could have managed making those decisions without me. And I don't think I could have made them without her. So I noticed that really came alive during COVID when patients were isolated, they weren't with their families. The emotional burden on the staff increased because we were their only support. But when patients are able to connect with their families, it just makes sense that as they're fighting for their lives, they have the reason to live right there at their bedside, and they can write, they can communicate, they can tell them what they want, what they need. And that really makes a difference to their outcomes. One survivor, also from ARDS, I have a picture of her ventilator outside the shower room. On a PEEP of 12 and 70%, she was showering herself while intubated. And I didn't mean to follow her out. We reconnected because I went to an ARDS group, and I asked who here out of the hundreds of ARDS survivors has walked on a ventilator. And only one person raised their electronic hand, and it was my former patient, Joanna. But I didn't know it was her. So I asked her, who else is doing this? And yeah, it turns out I had discharged her months before. And she said, now that I've listened to all these other ARDS survivors on this group, I realize I can't relate to them. They are fixated on their trauma, all these bad nightmares and hallucinations, as she called them. It's so real, I wouldn't even call it that. But for her, she was only sedated for a few hours during transport from an outside facility to the wake and walk-in ICU. Even in those few hours, I'm sure it was when she's getting an ABG done, she thought a nurse was trying to saw her wrists off. And she said, I'm so glad that that only lasted a few hours. If I had to spend weeks in that world, I'd be in a loony bin, she said. And she's like, it seems like everyone else is having a hard time going back to work. Their brains are messed up. Their memory's gone. I went back to running my own business 2 months after. And so for her, she was so grateful. She had the worst gag reflex I've ever seen. She was extremely memorable because of her gag. It's when patients come out of sedation and they're delirious and they're disoriented and now they have something in their throat, they don't know what it is. That's when we see a lot of gagging, coughing. We all know what that looks like, right? But that's not the same as someone coming out of sedation or out of the induction meds for intubation. That's different. Nonetheless, she did have a gag the entire time, and yet she was calm. She was able to cope with it because she had her coping skills intact. Nonetheless, she was so grateful. And now she lives in Tennessee, but she said she tells her husband, if anything ever happens to me, you fly me to Utah. I will not, I will not be sedated. And so it was just interesting. People always think that they always say, if I was intubated, I would want to be knocked out. And I appreciate that because of what we see during awakening trials. We see patients come out thrashing. We can see the terror in their eyes. And as nurses, we are not about that, right? We want to prevent harm, prevent suffering, prevent trauma. And so we rush to turn that off and we resedate them. And we feel like we've done the best thing for them. We've now spared them awareness, spared them trauma, but survivors tell us otherwise. So that awakening trials are sometimes like they're barely getting their head above water and then we shove it back down. So for these survivors that are awake and have heard the other side of it, they're so relieved that they don't have that kind of trauma and baggage with them. Are they excited to be on the ventilator again? No, but they're okay with it. One survivor that I interviewed, I think she's episode 3 of my podcast, she's had ARDS 3 times. The first time she got the conveyor belt approach of, intubate, sedate, and she watched babies burn for weeks. And it was vivid, it was real to her, and she was trying so hard to save them. And then her rehabilitation was really difficult, really hard. So when she was finally home and able, she was in her attorney's office having paperwork drafted, making herself a DNS. And this was years ago. She didn't know like what the research shows or what was possible. She just knew that she would never relive watching babies burn for weeks on end. So the next 2 times she had ARDS, she was sitting up, texting on her cell phone, totally fine. And she said, which was so profound to me, I'm not afraid of ARDS. I'm not afraid of mechanical ventilation, which if I had gone through ARDS 3 times, I would be. She said, I'm afraid of sedation. Do not sedate me. Sedation is what I am afraid of. So I have learned a lot from survivors. I've made a lot of assumptions before listening to their voices. And that's why I did the podcast, that we could hear it from them and make the research actually meaningful and applicable to the bedside.
How incredible that you've been able to talk to so many people who have gone through this firsthand and hear their stories. That's incredible.
It's changed
Hmm.
everything for me. And even still, I've done this for 3 years now. They say things and I'm like, oh my gosh, I wish I'd known that. That would have changed how I practice as a nurse, even in the wake and walking ICU, where I feel like they have the most humane ICU. There are still things that had I understood how much certain things meant to them, I would have had more patience when they were writing on their boards. If I had understood how much that pen and paper meant to them, I would have taken more time. I would have incorporated the family more. Like there's so many things I would have done. Um, but I say this for everyone and as well as for myself, because I did it a certain way, then I fell into the culture and I have a lot of regrets, right? People that have never done anything except for what they know, they're clinicians are not to blame. This is something that's been going on for decades. We've just all inherited these practices and I would say these problems. But I had done it a certain way. I knew how to keep patients awake and mobile. That's the power of culture. I went elsewhere and I just slid into what was normal. And so I could carry a lot of guilt. I try not to, because the purpose of all of this is to change it, to do something about it, not to weigh ourselves down and feel bad. So when I train teams, it's difficult because we carry a lot of trauma, a lot of guilt from COVID, but let's just use it to learn from it. And so when we learn these things, understand how these aha moments, just get excited. Just look forward to the future. What's done is in the past. And even the survivors feel that way. They're very aware of now what could have been, what maybe should have been, but they're not bitter. They're grateful to their clinicians. They love their clinicians, but they also want to ease the burden on future patients and the clinicians by having their voices heard.
What is the biggest challenge for an ICU to implement awake and walking of patients that you've seen? What do you see that's challenging in an ICU? And then we'll kind of dive into potentials of challenges for the ECMO population and kind of talk about that.
Yeah, I mean, there's so many barriers. And I think the first one people will bring up is staffing, which can be true. I mean, if we have 3-to-1 staffing ratios for nurses in the ICU, you can't do best practices. That opportunity is gone, right? But there are places like in Ireland where nurses are 1-to-1, but they still deeply sedate them. So I think across the board, usually the biggest barrier is sedation. Um, I, I was on site with a team a few months ago, and they didn't necessarily know. Some of them didn't know who I was or what I was there for. I was with another company called earlymobility.com, so they knew we were there for mobility. And when I said I'm a nurse practitioner, I'm excited to kind of dive into your sedation and delirium management. Even the medical director kind of drew back and said, "Wait, but you're here for mobility. Why are we talking about sedation?" And we see that in our research as well, that we isolate, put those in silos. And that is the biggest barrier. When we sedate patients, obviously we can't mobilize them. And I think when we talk about early mobility, that's very subjective. Early, when you look into the research of how the methodology of how studies have been done, early can be any time in the ICU. So it can be 3 weeks after admission. It could be sitting up at the side of the bed or passive range of motion before you're discharged, right before you go to the LTAC. That can be early. And then mobility can be passive range of motion, or it can be walking. It can be doing stair steppers. Um, there's such a spectrum. So I'm really hesitant about that terminology, even because it means something different for each team. But when we're talking about walking patients, obviously sedation is the barrier because you start sedation and they can't move, they can't contract their muscles. But then if we're looking to do what we've been trying to do, is we just turn sedation off sooner. That's very variable by clinician, depends on what attending's there, what nurse is there, um, what the staffing ratios are, that's very subjective. And even when we take sedation off, they could still be trying to metabolize the sedation off. They could still have a low RAS, or they could have hypoactive delirium, or they could have hyperactive delirium. And now they're agitated and thrashing. And now we're more inclined to rush back to sedation. And again, we don't have the opportunity to mobilize them. So I would say number one is sedation. Um, there's nothing in the evidence that says that we have to sedate patients right after intubation. Nothing. I've scoured the research. That's a cultural practice. That's an assumption. It's a reflex that we're trained to do. So, one of my physicians from the Awake and Walking ICU, told me that when he first started, he came right out of fellowship. He thought he had his groove, and he intubated his first patient in the ICU, turned to the nurse and said, "Okay, what do you want for sedation?" And, the nurse kind of drew back and said, nope, not here. That's not what we do here. Please never say that again." And he was really surprised, but that was just the conveyor belt approach, right? Um, but in reality, the patient that he was intubating, in retrospect, didn't have an indication for sedation. There are indications for sedation. If a patient has intracranial hypertension, seizures, inability to oxygenate with movement, the severest of ARDS or cardiogenic shock, there are times when it is necessary. So that's why it's important to critically think. But that's not what we've generally been doing. And so when we start sedation, we're automatically giving deliriogenic medications that are also myotoxic. So we're going to have later, and on the backside of critical illness, if the patient survives, delirium and severe ice-acquired weakness. And both of those are going to make it much more difficult to mobilize a patient. When you have a confused or lethargic or agitated patient, it takes more people to mobilize them. When they've been atrophying during critical illness, absolute disuse of their muscles, also with myotoxic sedatives, now you're going to have more people required to try to sit up at least, um, essentially an adult infant. So all of those make early mobility very difficult in general, and especially to walk them. You've taken away their ability to walk. It should be the extreme exception that a patient walks into the hospital and rolls out. But we've culturally allowed that to become the norm because we haven't known any other way, and we especially haven't experienced any other way. So, I sound like a crazy person initially, but what teams get to experience is, unless there's an indication for sedation, let that patient come out of intubation, or at least out of maybe an hour later, once the paralytics are worn off, if that's what we've given, and reorient them. Give them a pen and paper. Let them know what's going on. And even unless there's a contraindication to mobility, let them sit up. Let them get up. If you walk them right away, it normalizes being on a ventilator. Their brains get clearer. They're able to synchronize with the ventilator better, which sounds totally counterintuitive, but I swear by it. They get a sense of empowerment. It's more comfortable for them. And if they're walking right away and frequently, then now we've got a much easier and safer patient to mobilize throughout their time on the ventilator, unless their status changes. So timing is one of our biggest barriers as well. So when we start sedation and wait till later, it's going to be way harder than if we let sedation come off, prevent delirium, prevent ICU-acquired weakness, get them moving right away. Now we've got 2 or 3 people to walk a vented patient versus 6 people to dangle a patient.
And is there a standard progression and evaluation tool that you recommend to practically implement early mobility in the ICU?
Yeah, I feel like there's no perfect tool, but I do like Johns Hopkins tools, the highest level of mobility, the AMRAMP. Um, some teams use BMAT, MSST, those kind of things. I feel like those other tools are a little bit more applicable for the med surg floors. As for the continuum of care, my concern about BMAT, MSST, those kind of things is that it can require patients to follow commands. and to do certain things that aren't necessarily applicable to a lot of our AC patients. In my mind, if a patient cannot follow commands, they are probably more important to mobilize because they likely have delirium. And mobility is a huge tool to treat delirium. What I've seen is that some teams have implemented those other tools, BMAT, things like that, without allowing for critical thinking and giving the tools for critical thinking. So, I've been on site and said, oh, that patient is delirious. They're like a RASS of 1 or 2. They're agitated. He'd be a great one to dangle because it would wear him out. It would treat his agitation, and we then probably wouldn't need sedation. But the nurses are panicked because they say he can't follow commands. We can't mobilize him. So these tools should have the objectives of giving us a common vocabulary so we can communicate to each other. Nurses should be talking mobility. The next nurse, their MSST of 4, they are AMRAP of this, so that we all have the same understanding of what someone's mobility level is, what they've been able to do, so that we can continue that. It also helps us prepare to know what goal of mobility are we anticipating as we start to mobilize a patient. But they can become barriers. So if we don't provide critical thinking and with nurses that understand the why, then it can almost be an excuse or a barrier to do highest level of mobility. So I feel like the Johns Hopkins tools are the most applicable and the most beneficial for ICU settings. And again, they're just to help us assess and communicate. But we should still be using critical thinking and looking at the big picture.
Have you seen that length of stay in hospitals and mortality decreases?
Most research is really supportive of this. And when we're looking at early mobility, I will say it till I go blue in the face. And obviously I've gone hoarse from talking about all this, is that our mobility studies are not perfect. Look at the methodology behind these studies. If you see a study that shows, one study can show that early mobility definitely decreased time in the hospital, decreased mortality, improved psychological outcomes, physical outcomes, quality of life, decreased readmissions, right? We have just vast evidence supporting all of that. But then there are studies that show that it doesn't change length of stay, doesn't change mortality. Look at the methodology. What kind of mobility were they doing? Were they doing passive range of motion while patients are sedated? Because that can still count as early mobility. That's usually how those studies are done when they show that it didn't really change outcomes. But when you have highest level mobility early on during the stay, that's when we see the biggest bang for our buck as far as decreasing time on the ventilator, decreasing mortality. I did an episode a little bit ago, I think it's episode 119, don't quote me on it, my podcast with a team in Texas that started a mobility program during the thick of the Delta wave of the COVID pandemic. And they realized that I think about 75% of their patients were dying. And they said, this obviously isn't working. Why not try something else? So they started taking sedation off and getting patients up. They decreased mortality by 30% during the thick of the pandemic, which is amazing. So we have a lot of evidence to support that. One recent study I will mention, the team study coming out of Australia. I have an episode with the author of that study as well, including Heidi Engel and Dr. Wes Ely, where we're talking about how that study was done, what the outcomes were, because that has shooken the community as far as the discussion with early mobility. They concluded, if you just skim through the abstract, the conclusion says an increased dose of mobility did not impact time in the hospital or mortality. But when you look at the control and the intervention groups, there were only 12 minutes more of mobility between the groups. They were also sedated with a median RASS of -3 for about 5 to 7 days before they started mobility. So you already have massive muscular atrophy, delirium going on, and then you're having to rehabilitate patients. So the question is, does 12 minutes more really make that much of a difference once that much damage is done? But what the community has interpreted is mobility does nothing. I mean, that is what I'm hearing at conferences. That's what I'm hearing at the bedside. People say, well, what about the team study? Because now we know mobility does nothing. So I, again, will say it, tell them blue in the face, take a pause, look at the methodology. How is it done? What are we really assessing here? And is there strong enough evidence to make those conclusions? I think that study is really powerful because it shows us really the impact of our sedation practices. The main two barriers to mobility were agitation and sedation. And the agitation was probably because of delirium because they had been automatically sedated, and now we're trying to take sedation off. So we know that mobility improves all these outcomes. It decreases hospital-acquired infections. For every daily increased level of mobility, there's a 40% decreased risk of hospital and ventilator-associated pneumonias. So forget the 30 degrees. I mean, don't forget it, but just keep in mind that as we mobilize patients, they're going to be able to avoid those complications much more powerfully than just how they're positioned while they're comatose.
And today you are speaking to ECMO specialists and ECMO teams from all over the world. Is there encouragement or word of wisdom that you'd like to share with them?
Every patient is so different. And if patients on ECMO, likely have had a hard journey, long journey. I worry about patients that are coming from outside facilities that have been sedated and immobilized for a long time, and now they're coming to ECMO as their last chance. And that's a lot. That's really hard on your team. That's a lot. The biggest thing I can recommend is that you really understand delirium and ICU acquired weakness. Listen to survivors talk about what it's like to be sedated, because I can pull out statistics about sedation for days. I can talk about the numbers. What's most impactful to our practices, I perceive, is understanding what patients are actually experiencing. Um, I didn't know that sedation is not sleep. I didn't know that it disrupted the brain activity so severely that it prevents sleep, and that's one of the main reasons uh, it causes delirium. So when we understand it that way, when we're at the bedside and we have a patient that's sedated, we have to remember they're not sleeping. They're at high risk of having severe delirium. What is that like during sedation? And then after, how will their life be impacted? How will that impact their chances of survival? Delirium doubles the risk of dying in the hospital. So we need to really respect these sedatives as high risk medications that are sometimes necessary, but should be the exception. And when we do have to give it, we need to give the safest sedatives for the lowest duration and shortest duration and lowest dose possible. So understand delirium, do the research. You're welcome to listen to my podcast, listen to survivors. They tell it much better than I can. Um, and then really reevaluate your sedation. Ask, is it necessary? Understanding delirium and sedation will help us navigate those awakening trials. If you're getting patients from an outside facility or patients that have had to be sedated, and now that indication for sedation is gone, now it's your turn to take it off. That is a hard thing. I think that's one of our barriers too, is because we're doing awakening trials in general at 5 o'clock in the morning with one lone nurse. That's how I learned awakening trials. You do it on the night shift, no one else is in the room, you turn sedation off just long enough to see them start to move their limbs, thrash, then you turn it right back on and you check the box. And that's how you know that they can't tolerate the ventilator, is what I was told. Um, Now, survivors will tell you, no, I was trying to tell you not to kill me. I was trying to ask for a pen and paper. I was trying to get away from the monsters. I thought there was a snake down my throat. So when we understand their perspective, how we approach those waking trials will be different. And really, what we really should be doing for a successful awakening trial to get sedation off, because that should be our goal, unless we see actual physiological instability that requires sedation, we should be trying to get sedation off. But that's not possible until we have family at the bedside, comforting their loved ones, helping them connect to reality. We need the delirium SWAT team, which includes speech therapists, occupational therapists, physical therapists. So if we have a culture, which happens sometimes, where they're like, oh, this patient's too agitated for physical therapy, they're too confused for occupational therapy. That's a huge problem because they're the ones that come with a big toolbox full of things to treat delirium, to treat the agitation, to mobilize them, to keep them safe, and to wear them out so that nurses don't have to turn sedation back on. So understanding delirium is going to help us understand what prevents it, how to treat it, who has the tools, how do we approach an awakening trial this way. It should not just come down to one lone nurse trying to wrangle a patient or seeing, hemodynamic instability happening because of agitation. We need to be using the entire team. And then we also need to understand mobility, but zooming out, we need to understand how important the muscles are as a vital organ for survival in and after the ICU. And so understanding that will help us prioritize mobility. It's not just a fluff um, fad. People think that air mobility is just what the academics are talking about. This is life-saving. This is make it or break it for many patients, not just if they survive, but what kind of life do they lead after. So when we really understand the science behind it, understand it's safe and feasible, then we're going to be able to work together to make sure it happens. We will prioritize it as much as any antibiotic, knowing that that saves their lives. We also need to understand what real parameters are. I think some units will say we can't mobilize patients if they're on vasopressors, and then other CVICUs will say, oh, we titrate vasopressors up and inotropes so that we can mobilize patients. We use those tools to mobilize them. We change the sweep. We change the settings on the ECMO so that we can facilitate mobility. And so really we need to look at what's cultural, what's in the evidence, what is best practice, how do we really humanize our approach so that we have patients as awake and mobile as possible, and then work together to get that done. Also, femoral cannulation is not a contraindication to mobility. So there are some myths out there that are, again, some of the barriers that we're facing. I think for me, because I've watched so many patients on mechanical ventilation, and probably just depending on the ventilator only and very sick lungs, I actually felt more secure, like, okay, they're really going to be oxygenated. Like, they're really going to be okay. And seeing, that their vitals are stable, that they're okay, that just feels better, more comfortable. So it wasn't super shocking to me, other than there's awe. Like, I just have so much respect for the competency of the team to say, I'm on the ventilator, I'm on ECMO, I've got the patient, I've got the equipment. Like, it's just a well-oiled machine. So for me, there's just a lot of respect and awe at the beauty of such a well-orchestrated process. Um, and then zooming out more, just seeing how joyful people are. Like, it's just a humanizing experience, and just knowing that they're in some ways going the extra mile, right? Like, some ECMO units don't do it at all, and yet this team is, and usually it's because they understand, they're educated in the process, the why and how, and they really care for that patient. Not that when you don't do it, it's not that you don't care for that patient, but when you're putting that effort together, it's because and you envision that patient walking out the doors. And to me, that's just really inspiring and exciting. So there's some shock, there's some like humility and respect for how sick that patient is, but also there's a lot of hope that this is the best thing for the patient, that patient's going to survive and thrive, and that this team is going to continue to provide that care for other patients.
Well, thank you for hopping on today and sharing with us. It's so good to see you and kind of talk to you in person. A lot of respect and acknowledgement for everything that you're doing for ICUs all over the world. Thank you so much.
Oh, thanks to your community for caring about this and for jumping in on the ICU revolutionist bandwagon.